Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, the topic is diabetes and our greater understanding of type 1 diabetes, long called childhood diabetes. Johns Hopkins epidemiologists Mike Fang and Liz Selvin talked to Stephanie Desmon about their research that busts some myths about the disease. 4 in 10 adults with type 1 diabetes are diagnosed after age 30, for example, and why much more needs to be learned before the medicines changing the lives of those with type 2 diabetes can be used to treat type 1. Let's listen.
Mike Fang and Liz Selvin, thanks so much for joining me.
Thanks for having us.
Thank you.
So today we're going to talk about diabetes, and I want to sort of hear about some of your research that really challenges what we have long understood about type 1 diabetes, which I know you guys have already corrected me, is no longer called childhood diabetes. And maybe we should start with the research that you've done that tells us what the age of onset really is. Mike?
Yeah, thank you. So you're right. Type 1 diabetes, for the longest time, was called juvenile diabetes, and it was thought to be this disease that had a childhood onset, right? So it was something that occurred only in childhood, and when occurred in adulthood, when diabetes occurred in adulthood, then that would be type 2 diabetes. But it turns out there's been sort of recent studies that have looked at this issue a little bit more, and it turns out approximately half of cases of type 1 diabetes may be occurring during adulthood, right? Past the age of 20 or past the age of 30. I think the limitations of these initial studies is that they've been in small clinics or in one EHR system, one health system. So it's unclear whether or not it's just that particular clinic or it sort of applies to the population more broadly. We were fortunate because the CDC has collected new data which explores type 1 diabetes in the US. And one of the questions they included in their national data was, do you have diabetes? Yes, no. If you do you have type 1 or type 2? And at what age were you diagnosed? Right? And so with these sort of key pieces of information, we were able to characterize how the age of diagnosis of type 1 diabetes differs in the entire US population.
Are type 1 and type 2 diabetes different diseases? Liz?
Very different diseases and really a very different burden. And I think, I, for my whole career, have been very much a type 2 diabetes epidemiologist and been very excited to expand into work on type 1 diabetes. There's approximately about 1.5 million adults with type 1 diabetes in the US compared to 21 million adults with type 2 diabetes. So we're really, in terms of the total cases of diabetes, only 5 to 10% have type 1 diabetes. So even in our largest epidemiologic cohorts, only a small percentage of people have type 1 diabetes. So we just don't have the same national data, same epidemiologic evidence for type 1 diabetes that we have for type 2. So that's really been a focus of our research, is sort of trying to understand and characterize the general epidemiology and the population burden of type 1 diabetes.
What is it about type 1 that makes it so hard to diagnose?
Mike, I'll let you handle this. You've thought a lot about this.
I mean, so when it occurs in childhood, so I guess it tends to be that the presentation of the symptoms varies by the age of diagnosis, right? So when it occurs in children, it tends to have a very sort of acute presentation. So the diagnosis is sort of easier to make. When it happens in adulthood, the symptoms often are milder, right? And so in those cases, it's often misconstrued as type 2 diabetes. And there's some studies that have suggested that when type 1 diabetes occurs during adulthood, about 40% of those cases are actually misdiagnosed initially as type 2 cases, right? So this whole age of diagnosis factor is really, really important. And so understanding how often people get diagnosed at later ages is really important, but also understanding that the disease can occur at these sort of later ages is important for sort of correctly diagnosing patients.
And correctly treating them. right?
And for treating them. Yep, correct.
Because it's different treatments. Talk about that.
So for patients with type 1 diabetes, they're going to require insulin. And for type 2 diabetes, they can require insulin, but that often occurs later in the disease as sort of oral medications become less and less effective.
And I'll say, Stephanie, one issue is because of the epidemic of overweight and obese in the general population, we're now seeing a lot of people with type 1 diabetes who have overweight, who have obesity. And so that can contribute to issues around misdiagnosis, because people with type 1 diabetes will have signs and will present similarly to type 2 diabetes. So they'll have insulin resistance, potentially as a result of weight gain, metabolic syndrome. And so there can be this sort of conflation and confusion about type 1 and type 2 diabetes. Some people call it double diabetes. I really don't like that term, but this idea that if you have type 1 diabetes, you can also have characteristics of type 2 diabetes as well.
And I understand that type 1 used to be considered a thin person's disease, and that's not really the case anymore.
Yeah. So in this same data set, in a separate paper, we also explored the issue of overweight and obesity in persons with type 1 diabetes. And we found that approximately 62% of adults with type 1 diabetes had either overweight or obesity. And this was very, very comparable to the general US population. And it turns out this whole notion that people with type 1 diabetes are just this sort of thin population just doesn't hold, right? They have the same rates of overweight and obesity as the average US adult. I think the important disclaimer to that is just because they have average the same as sort of the general US adult, the management of weight management in this population is way different, right? You can't just decide to go on a diet, or you just can't decide to go run around and start jogging and engaging in rigorous exercise. For this population, that is an incredibly dangerous thing that it can be a very, very dangerous thing to do. And so the weight management piece is very, very different in this population.
Since we're on the topic, I wanted to ask, everybody's talking about the Ozempics and the Mounjaros, the GLP-1s for diabetes, for people who are overweight, to lose weight and to solve their diabetes. So where does that fit in with this population?
Yeah, so these medications, they're used to treat type 2 diabetes in the setting of obesity. And they're incretin hormones, and they mediate satiation. They reduce appetite. They slow gastric emptying. These are all the things we've heard, right? And they lower energy intake. So they're really powerful drugs. And now, as Mike discussed, we know that a lot of people with type 1 diabetes are also facing the challenges of being overweight or obese. And so they may be helpful in type 1 diabetes, but they're not approved for the management of obesity in type 1 diabetes. And there aren't any data, there aren't really rigorous data to help guide their use in people with type 1 diabetes. But I suspect they're going to be increasingly used in people with type 1 diabetes.
I will add to that. I would be remiss if I didn't also sort of mention that the diet and exercise piece in people with type 1 diabetes, right? The other piece of sort of managing weight, and it's thought to be foundational for type 1 or type 2, is dieting and exercising. And it turns out there's not good guidance on how to do this in persons with type 1 diabetes, right? In type 2 patients, there's large, rigorous trials. And so those guidance are well established and well laid out. But for patients with type 1 diabetes, we're really just starting to figure out how to safely and effectively manage your weight via lifestyle. And I think that's an important area of research that should continue moving forward.
And just to be, sort of to expand on that, right? And that's what Mike said is really important, is that weight management in type 1 diabetes is complicated by insulin use and avoiding hypoglycemia, or your glucose going too low. So that can be an acute complication of exercise. So, that really changes in exercise and diet can be super tricky for people with type 1 diabetes. And because you'll need to adjust your insulin dose to keep your blood sugar at a safe level and avoid it going too low. In people with type 2 diabetes, we have this really strong evidence base for what works. And we know, modest weight loss can help prevent the development of diabetes and prevent the progression of diabetes, and preventing weight gain is really important. We have all these new drug therapies, but in type 1, we just don't have that evidence base.
Is there a concern about misdiagnosis and mistreatment? I mean, are you going to be, maybe you think your patient has type 2 and they really have type 1, and this causes all kinds of havoc?
I think it's the insulin is sort of the overriding concern, I think, right? And so actually it's funny, we in that obesity paper, we also looked at the percentage of people who said their doctors said that they should be engaging in more exercise and dieting more. It turns out that people with type 1 diabetes receive this information the least, right? They were the least likely compared to people with type 2 diabetes, and for people with no diabetes, they were least likely to get this information from their doctor. And I think this does speak to potential fear in providers, right? If I give this guidance to my patient who is type 1 and is using insulin, I tell them to start exercising more. That poses really important dangers, right? And, they may lose a few pounds, but there's this benefit reward ratio may not work out. I think providers may be hesitant to say, look, just go engage in lifestyle. And so this is really why it's important to have those studies and have that guidance so that patients and providers will be comfortable in improving lifestyle management.
Where is this research going next?
I think what's really clear from these studies is that the burden of overweight and obesity is substantial in people with type 1 diabetes, and it's not adequately managed. Going forward, I think we're absolutely going to need clinical trials and clear clinical guidelines and patient education that address how best to tackle obesity in the setting of type 1 diabetes.
It's got to be confusing for people, right? Also, they're hearing about all these people losing all this weight on these drugs, and they're like, well, I have diabetes, and they go to their doctor, and their doctor's like, yeah, but that's not for you, right? You have the wrong kind of diabetes. Is there some kind of element of that?
Well, hopefully it's being handled in a little bit more sensitive way than that. I really think that, these drugs are being used by all sorts of people in whom they are not indicated. And I'm sure that people with type 1 diabetes are accessing these drugs. And I think the cat's out of the bag. And I think the question is, are there real safety issues? And we really need some real thoughtful discussion about this and some real evidence to make sure that, we're doing more good than harm.
That's right. Just to add to that, there have been some studies that have looked at the use of some of these medications in people with type 1 diabetes in various other health systems. And it's not that uncommon, right? Dr. Selvin's group has published a paper estimating that about 15% of people with type 1 diabetes are on a GLP-1. So it's not that uncommon, right? And it's not indicated, so it's off-label. And we really don't know. We suspect it'll probably cause lots of weight loss, but some of the safety issues, really, we don't know. We don't have great data on what potentially can happen to individuals. And so again, more studies are needed for sure.
The other big part of diabetes that we hear about a lot is insulin and the price of insulin. And Mike, I know you recently did some research on people accessing insulin despite its high price or when the price goes down. Can you talk about that?
That's right. So there was a survey recently in these data that we analyzed that asked, has there been at some point during the year, were you not using insulin because you couldn't afford it, right? Some version of that question. And about 20% of adults who were under the age of 65 said that at some point during the year, they couldn't afford their insulin and that they engaged in what's sometimes called cost-saving rationing, right? So that was the main finding from that paper.
So that's a lot of people who can't afford their insulin. I know you differentiated between under 65 because Medicare is now covering 65 and older on the cheaper insulin. But there's a lot of people out there who still find affordability as an issue. Can you talk a little bit more about that?
That's right. So, yeah, the fight is not over, right? Just because there's national policy, there's state policy, and now manufacturers have been implementing price caps as well. That doesn't necessarily mean that the people who need insulin the most are now able to afford it. And there was actually a recent study in the Annals of Internal Medicine looking at this issue where they looked at states that adopted or implemented out-of-pocket cost caps for insulin versus those that didn't, and how that affected insulin use over time. And what they found was that people were paying less for insulin, but the use of insulin actually didn't change over time, right? So the out-of-pocket costs slightly went down, but the overall use was relatively stable. And so I think this suggests that we need to do more, right? That the $35 cap is definitely an important improvement, but that more policies and more efforts are needed moving forward.
Liz.
And it doesn't cover all formulations, right? So there's still a lot of formulations of insulin that are very expensive, and $35 a month is not cheap for someone who is on insulin for the rest of their lives.
So what kind of message would you like to leave our listeners with, Liz?
I think I'm really excited that we are getting more and more national data, and we're sort of bringing epidemiologic methods and emphasis to the study of type 1 diabetes. I think the prior studies have been in really select cohorts and really small, potentially ungeneralizable groups of people. And I really think that I'm encouraged by the work that Mike is leading and that our group is doing, and really excited to bring a rigorous epidemiologic lens to the field of type 1 diabetes.
And I just want to add to that. I think more data are going to result in better health outcomes for patients. Right now, the clinical guidance for how to manage type 1 diabetes is largely taken from type 2 diabetes. So all those studies, most of the studies, particularly the clinical trials, have been in people with type 2 diabetes. And so we just take those findings and we're like, well, you have type 1 diabetes, close enough. And so this is how doctors should manage your disease. That's a strong assumption, right? And that's not necessarily optimized for those patients. And so as we get more and more data, we're going to be able to tailor guidance for patients with type 1 diabetes in a much more individualized way. So I'm very, very excited about that as well.
Mike Fang and Liz Selvin, thanks so much for joining me.
Thank you.
Thanks for having us.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ceciri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.